All right, welcome back everybody. If you could take your seats, we've got a very busy session now, but until lunchtime. We've got a big policy session and we have the Prime Minister's visit, so we need to keep to time. So thank you. It's my pleasant duty now to introduce the convener of our next session, Dr. John Zorbas. John is the Chair of AMA Council of Doctors in Training. He's currently an advanced trainee in both emergency medicine and intensive care medicine. He studied it in WA, completed his baseline degree there. He seems to have about 6 on the go. And he's worked in WA, New South Wales and now in the Northern Territory. He's a registrar at the Royal Darwin Hospital. He's completing a Masters of E-Health at the University of Tasmania and a graduate diploma of clinical ultrasound at the University of Melbourne. Welcome, John.
Thanks very much, Bev. That's very flattering. You left out the part at the end where I spend most of my time just driving around the Territory in my Land Rover Defender, which is slowly falling apart. I'll just invite the panel to just take their seats and I'll introduce everybody as we come up. Can I move around? Am I good? Well, look, I'll wait here till we get that sorted. But look, today's session is on doctors' health and well-being. This session focuses on the health and welfare of doctors across the country. This isn't a session just focused on doctors in training, but doctors and medical students across the entire profession. We're here to examine current and emerging issues relating to doctors' health and well-being. We're here to discuss the current initiatives across the country to promote doctors' health and well-being during training. And we're also here to identify additional strategies and mechanisms to improve access to services and support. So as the panel takes their seats, I'd just like to quickly introduce your panel for today's discussion. From near to far, we have Dr. Anjali Dhulia. She's the Director of Medical Services and Quality at Monash Health. We have Ms. Marie Jepson, Executive Director of the Tristan Jepson Memorial Foundation. We have Dr. Coyote Colves, Principal Research Fellow at the Australian Institute for Suicide Research and Prevention. Empty seat for some straggler. Then we have Ms. Fiona Shand, a Research Fellow from the Black Dog Institute Lifespan Strategy. And then Dr. Jeanette Randall, she's the Chair of Doctors' Health Services. And Dr. Bavahuna Manoharan, who's representing AMA Queensland, discussing the Resilience on the Run program. So with that, I'll see if my microphone's working yet. Yes, it is. Excellent. We want today to be a fairly dynamic session. I know this is an issue that a lot of us could talk at length about for a very long time, but we don't have a long time because some chap called Malcolm Turnbull is coming after us. The issue itself, the reason we're discussing it is because it's something that is ever present. I don't think this is just about recent suicides. I think this is about an issue that's been on the AMA's radar and certainly an issue that I've known about since I was a medical student. One of the focus areas was the Beyond Blue National Mental Health Survey in October 2013, and that showed us or taught us that a quarter of doctors had previously considered suicide. And that's a staggering number when you think of our profession as a whole. More importantly, 1 in 10 had actively considered suicide in the last 12 months for the period of the survey. So this wasn't just an adjustment period at some point during the career, this is something that is actively still present. There's increased rates of cynicism, increased rates of burnout amongst doctors in training and medical students. But interestingly, there's also increased levels of resilience and an increased ability to seek help. Now from that point, we've had a number of papers and there's areas of research you'll hear about today. But there's no clear answer, there's no clear obvious problem and no clear obvious solution. And so today's session will help to flesh out some of that and see where we arrive to at the end. In terms of questions, delegates were given the opportunity to submit questions before the session, and we do have some, and thank you all for your submissions. We'll try to get through as many as we can. There's also questions that we'll be taking via Twitter. Unfortunately, I don't have the Twitter feed on my magical screens in front of me, so if we can attend to that, I should be able to take any questions that you send to Twitter with the hashtag AMANatCon. Alternatively, if you don't know how to use Twitter, just text Mukesh, and I'm sure he'll be able to get it sorted for you. Just quickly like to note the incorrect spelling of Dr. Coyote Colves in the handbook with regards to published research. It should read Colves, not Ives. I'm sure you figured that out. But the link is there in the online reference of the study on the NatCon website. So that's your panel. That's today's discussion. I'd like to start by talking about the idea of the access to support services and stresses that are present in our environment. And with that, I might lead with Jeanette. Jeanette, the Doctors Health Service has been instrumental in establishing a consistent suite of services across the country, which wasn't present before. Do you mind just having a bit of a chat about what types of services that are offered?
Yeah, sure, John, and thanks very much for the invitation. I think it's really important to acknowledge that there have been Doctors' Health Services in many states for a really long time. Those services, South Australia and Victoria have had more established services, but certainly in the other states that's really been a doctor with a phone. So there have been many of your colleagues who have done a lot of really fantastic work over a really long period of time, and I think I just want to really acknowledge their efforts today. But fortunately, 2 years ago, the Medical Board and AHPRA made available $2 million per annum of funding through an agreement with the AMA, and with that funding we've been able to ensure much more certainty for Doctors' Health Services around the country. And so we now have physical presence in most states of Australia, and we have outreach services into the smaller states. So what do those services look like? So they are, as I said, physical presence, offices with medical directors and administrative support staff and social workers as well in some states. And they're available to take calls from doctors and also doctors' families and colleagues and employers who may have concerns around doctors' health issues. So really we're a first port of call. The people who are talking to you on the phone very much are your colleagues and peers. They understand the issues that you're calling about, and our job is really to provide some immediate advice and support, and then to help people to access the care that they need. So part of our job is to build referral networks so that we have panels of doctors and GPs and specialists that we can help people to access, and we can refer people to those, and also other kinds of support services that people may need. In addition to that kind of very one-on-one support for people, we also do quite a lot of work just in raising awareness around doctors' health issues. So our services go out and talk to medical students, doctors in training. Recently we did an education session for the GP supervisors in Victoria. So we do a lot of work trying to raise awareness around doctors' health issues and make them aware of the services. Probably, yeah, John. Yeah.
I think one of the biggest problems or questions that we get is about surrounding the stigma of seeking help for mental health, which in a profession like this is bizarre but also troubling. Yeah. What is DHS doing, or what can be done, and I might open this up to the panel as well, to destigmatise mental health, the diagnosis of mental health, seeking treatment and assistance for mental health?
Yeah. Look, John, I think that's a problem we all kind of own, don't we? So part of what we do is we do training, run training sessions for doctors who are treating other doctors, so that we're trying to upskill all of us to be more responsive and to provide safer and more appropriate care for our colleagues. So I think that's part of it, that when you as a doctor patient do seek care, you get the right kind of care at that point in time. And I think really it's around people like Doctors' Health Service staff and doctors really taking a leadership role around some of that stuff, and trying to normalise health-seeking behaviour. I think it's fair to say that doctors are people. That might come as a surprise to you, but we are people too, and we have all of the same kinds of health issues that everybody else has. And I think there's a bit of a misconception that Doctors' Health Services are all around mental health. In fact, a lot of people people ring us around physical health issues, cognitive concerns, etc. So while mental health, it's important to respond, I think it's important also to recognise that we have all of the same kinds of health issues as everybody else.
On that, I think the important thing there, what you mentioned, was training the providers and making sure that they understand what's required of them as a practitioner treating another practitioner, because you're not treating another patient, you're actually treating another doctor. And I think there's a stigma around a doctor actually approaching a health service and asking for help in especially in environments outside the WA where there's mandatory reporting. But there's also a general lack of understanding by some practitioners about what the legislation is and what is the threshold. When do I have to pick up the phone or write a letter to AHPRA about a practitioner? Should I just do it for everyone because that way I won't ever get in trouble? And I think that is a real concern on both ends. So the education goes both ways, and I think that's one of the critical things, and I think that's what the Doctors Health Service can actually do, is improve the general education amongst our practitioners.
From our experience at Monash Health with the VDHP, the Victorian Doctors Health Program, I mean, it's been one of the best partnerships we've ever made. From our experience, one of the things that I notice in the outcome of someone who has a mental illness and how they manage it along with their work and life, people who've been more open and been more willing to work with the organisation and with the health Doctors Health Program, they have had a much better outcome going forward. So because we've and on Bav's point, not every mental illness needs to be reported to AHPRA. It is all about, are you managing it well, and in that space, only if your mental illness is causing an impairment, which then affects patient safety. Only that is, and that too, the threshold is really, really high. Only then anyone thinks about reporting people to AHPRA. So I think that's something that more we talk about, more we sort of discuss, will definitely reduce the stigma that we're all worried about and talking about.
I suppose one of these things relates to the difference between the letter of the law and the reality, in that, yes, there are some definitions around impairment, but there is a lot of subjectivity. There's a referee paper that's required for a job application in one state in Australia for a public sector job, where the first question for the referee is, does your referee, or does the person you're writing the reference for, have a mental illness? Doesn't ask about impairment, just says have a mental illness. Now you might as well ask them if they fractured their leg once upon a time. And I suppose that's the reality we're dealing with, is often what is in practice doesn't match the intent of the law. But while we're on the topic of systems, I might ask, you talked about doctors being humans, and yes, that is, I think, a surprise to most people. One of the questions we received was from Dr. Rosalind Forward, who's the co-chair of the AMA WA Doctors in Training Welfare Subcommittee. And she wanted to know what is happening nationally to cover the myths around mandatory reporting and make AHPRA more human. So when complaints are made, they remember that he's a human at the end of this. And Ros wasn't the only person to ask this question. The word human came up a lot when we were talking about the way the system processes it. Now, whether that system is AHPRA and mandatory reporting, or whether it's simply wanting to seek assistance for your mental illness, the system is the system, and that's what they're talking about. And I wonder whether there's anybody in the panel who might want to speak to the idea of making a system that treats us more as humans rather than as statistics.
John, I could certainly make a comment around the mandatory reporting issue. I think, as Anjali said, the threshold is high, but, we certainly have a lot of stories around people being inappropriately reported, and we just have a very strong general sense of fear and reluctance to present for care, and we know that this is one of the barriers. So I guess from my perspective, while I think we should continue to educate people around mandatory reporting and what that looks like, I really do think the time has come to remove the onus on treating practitioners to report. Now, that's not to say that, we don't all retain an ethical and professional responsibility in that space, but, we've got to create safe environments for people to seek care, and if that's one of the things that's going to help achieve that, then I think really the time has come, to do that.
Could I just comment? I mean, with the lawyers, what we found was that if there was mandatory reporting, which was the case in Victoria not terribly long ago, that there were lawyers who would quite deliberately not go to the doctor even though they were quite ill, so that they couldn't lie on their application for a practicing certificate. And in fact, it drove the issue underground, and it meant that yes, you complied with the regulation, but in fact it was a time bomb ready to go off. And what is the goal? Is the goal that we get people to seek help early and to manage their condition, or is it that we police mandatory reporting? And it has just recently been thrown out by the Australian Law Council and the Australian Bar Association that there will not be mandatory reporting because the impact will be more detrimental to the profession and the practice of law if mandatory reporting is brought in.
It's a good thing we're having this discussion later today, not that that's a pointed direction for discussion. We've touched a little bit on the interplay between what the system does and what the individual does. And I might move to the discussion around self-help and reflection and systems that are in place for that. So I might move to Fiona. Fiona, the Black Dog Institute runs a number of programs, but I want to hear about the e-health interventions that they have for tackling depression. Do you mind giving a bit of a background to how that works?
Yeah, for sure. So I think just it's a nice segue actually, because we know that often the threshold for help seeking is quite high. And one of the reasons for that is not just around mandatory reporting, but also a person's belief. So when, not just amongst doctors, but amongst everyone, if there is a belief that this is not that serious and I can fix it myself, then that's also a barrier to help seeking. And one of the areas where any health intervention can assist is that it's a fairly non-threatening way for people to seek help. So people like the anonymity of it, they like the idea of being able to do it in their own time, at their own pace. And more importantly, we know that online CBT programs are as effective as face-to-face treatment. There's been a couple of fairly big reviews of that. So they are effective. And in fact, there was a study with medical interns going back a year or two or so now, and they used an online CBT program in the 3 months leading up to medical interns starting their internship. The reason for that was that they found that within the first 3 months of the internship, there was more than a threefold increase in suicidal ideation amongst these young people, which is pretty concerning. So it's obviously a really stressful period for them. And this was a US study coming out of Yale and USC. And so they actually used this e-mental health intervention. And what they found was that across that 12 months, compared to an attention-matched control group, the group who had completed the program actually had a 60% lower rate of suicidal ideation. So the idea was that they knew these young people were going into a very stressful year, to give them some skills to help them cope. So it's a preventative approach, and it was actually quite effective. So they not only work in the general community, but they also work with medical interns. So I think it's a kind of nice, accessible way for people to seek help. And in fact, a lot of the feedback we get is that doing something like this can then be a gateway to people getting some face-to-face help.
I think, we talk about the barriers to seeking help, and I think your comments on e-health interventions are an interesting one, because if we look at telehealth research in Australia over the last 10 to 20 years, telehealth facilities delivering psychiatric assistance and psychiatric services have above and beyond been the successes, and the failures have always been around the more, the requirement for examination and delivery of physical things, which is fairly obvious, yes. I think, but you've still got to prove what you know. Which I think does bring me to the importance of good data and research, and what we know, and more specifically what we don't know. I'd like to talk about whether we have a handle on doctors suiciding and whether we know that they are suiciding or not. Is a single vehicle accident a suicide, or is it an accident? And I might move to Coyote. Coyote, you've been able to use the data from the Queensland Suicide Register to compare suicide of doctors to other healthcare professionals in Queensland. Do you mind just talking a bit about what you found and how this might compare to the national data?
Sure. Firstly, what we did was the analysis using the Queensland Suicide Register, which is quite an extensive database starting from 1990. And we did analyze all the cases between age 25 to 64. And the first finding, of course, which is limiting all the analysis, is nevertheless, suicide in general is a relatively rare event, and we found still quite a small numbers of suicides in medical doctors, which to a certain degree limits the analysis. However, what we found was that significantly higher suicide rates or the risk of suicide when it comes to the female doctors, and we compared them to the educational professionals. So when it comes to the right comparison group, it's quite challenging because possibly not all the occupational groups are comparable, but at the same time we found the similarities that also education professionals have a higher education, have high levels of work stress, and also it's kind of to a certain degree has been historically male-dominated occupation. So we found that for females, the risk of suicide in female doctors was higher. At the same time, that wasn't the case when it comes to the males. And we found that at the same time, when we compared that to the rates of all suicides in Queensland, we didn't find a significant difference for neither males or females. When it comes to the specific factors, then we found that one of the major issue is possibly not a big surprise is the use of different types of poisonings, and we all know that the availability of different types of drugs is quite different when it comes to the medical doctors. One of the interesting things was also that when it comes to that compared to the different groups, we found actually that which a little bit contradicts with what has been said before, that that there is higher levels of reported psychiatric disorders. So one would think that is it really that, is it contradicting to the fact that there is less help seeking in medical doctors? Possibly it's not, but at the same time, if we know that it can cause to a certain degree, as it's mandatory, so it can cause certain extra stress. So maybe that's the reason why we found that fact. And of course, I don't need to say to you that there is high level of work stress, long working hours, etc. Our results are in line when it comes to them a little bit more recent study using the National Coroner's Information data, where they found also that despite comparing to all the different occupations and all the people working, they found that also females have a higher risk, significantly higher risk. At the same time, males don't.
I think you've mentioned the NCIS there and the idea of using coronial data. I'd just like to talk about the idea of a national suicide register. Now, the AMA has spoken in favour of this before, but I wonder, I might open to the panel to discuss whether you think there is benefit in a national suicide register, what form that might take, what do we need to be documenting, and how should we be documenting it?
Of course, sorry to take the first lead here, but when it comes to the benefits, what could be gained from different types of suicide registers is, of course, firstly, we do know actually how many suicides are occurring, how we can split it down, how many medical doctors' suicides are occurring in certain point of time. We can see the changes in their is it going up? Is it higher than in some other groups? Is it higher than in a general population? This is also this simple type of monitoring. We're also able, if we are implementing certain activities, we can evaluate them. We can see that, okay, was the very high rates some years ago, have our activities actually made a difference, considering we know that suicide risk is one of the important indicator of mental health and well-being. Of course, not the only one, but one of the possibly most extreme. Other aspect to it is also that the registers, again, when we design one, there are a million different questions. What should we register? What is the reasonable? What gives us enough data, information to plan future activities? Is it, are we maybe putting too much into it? Maybe it's too limited and we can't say plan anything based on that. But kind of this is what I would see as the main features when it comes to some benefits, but there might be some others definitely.
Yeah, Jeanette?
Yeah, and I think that when there is a suicide in the profession and that elicits an understandably very distressing response from all of us, that need to know is very strong, John, and I think it's kind of why did this happen, and we need to understand everything around why that happened. So I think that that's some of where the desire for better data comes from, because we really want to understand what went on in that kind of last phase of somebody's life. But the reality is that we already know a lot of the things that we can be doing upstream, to kind of, while I think data is important, we don't want to get too distracted by that, I think, because, if we focus all of our efforts down at that end, I think we've really missed a big opportunity for all of those upstream drivers. We need to create safe working environments for doctors, and we need to create safe environments for them to seek help. And so if we do that, then hopefully we won't have to count what comes at the end. Yeah.
I guess it's part of the solution. It's sort of a multifaceted approach, but you need to know the tip of the iceberg, which is the suicide. And we talk about trends and knowing, understanding interventions, because we're all scientists and we want to do something and see how it affects the outcome. But we also need to do psychological autopsies on each case and see, are there things going on that are individual and couldn't have been prevented regardless of all the interventions that we could have thrown at these individuals? Or is this more of a professional thing that we can affect? Is it a cultural thing that we can affect? I think in medicine, my background being previously in surgery, we had the audit of surgical mortality. There was the trauma registry that all states tend to participate in. And these aren't just there to sort of understand the numbers, it's also to see, are there certain trends happening? Are there certain factors that are causing these sort of events to happen more frequently? And you can apply interventions. But that's one solution. That's sort of that's not a solution. That's one part of the understanding the problem, but it's not the complete. So a national registry is almost common sense. It needs to happen, but it's not the end game. It's not what's going to fix everything.
I think we've spoken a bit about some of the upstream factors and safe working conditions and safe working hours and things like that. One of the questions that has popped up on the screen was from Patrick Tam in South Australia, talking about internship specifically and talking about making internship less stressful. If I'm being brutally honest, anytime I say a comment about that in front of some doctors, I get a couple of eye rolls and questions about, back in my day we did this. I would put it to those colleagues that internship now is not like the internship that you went through. When we discussed the intern review, we thought that we would be spending most of our time talking about what internship looked like and what it could look like. And in fact, what we did was spent 90% of our time just talking to the reviewers about what internship today actually looks like. And it looks like a computer. You can't see a patient for miles because you're too busy filling out forms. And so I would when we talk about health systems and stresses, I think it's always important to know what's going on at the moment and the importance of good data around what the system looks like now, not what the system looked like 10, 20, 30 years ago, and also what we want the system to look like in 10, 20 years from now. It doesn't have to be what we have now. But to talk about systems and healthcare environments and stresses, I'd like to move to Anjali. Anjali, you're representing Monash Health, and I've worked around the country and I've met a lot of doctors around the country, but I think Monash Health, people who've worked through Monash Health, it was the first time I'd had someone introduce themselves to me as a Monash doctor. And that was interesting. That was an interesting moment. So I just wanted to ask you about the vision for Monash Health and the wellbeing program, and this idea that no doctor at Monash will suffer in silence. Could you talk to us a bit about why you implemented this program?
Sure, thanks John, and that makes me really, really happy that someone introduced themselves as Monash doctors. So we've really been, so just for those who don't know Monash Health, we are the largest health service in Victoria. We have about 16,000 staff and 2,500 doctors, of which they're half and half seniors and half junior doctors in training. And we've been on this journey for a while now, and the Monash Doctor brand was launched about 5 years ago. It was an idea of our Chief Medical Officer that, one of the basic needs of people is belonging, and especially junior doctors who move from hospital to hospital, one of the things is that they don't really feel a sense of belonging to their workplace, and so that was one of our little sort of efforts to give people an identity, and I think that's really worked. And now Monash Doctors is a very well known brand. In terms of Monash Care, so that is our mental health and well-being strategy for Monash Doctors. Again, that's been a fascinating journey. We launched it in 2014, and how it came about was that the Beyond Blue survey, which we've been talking about, had just come out in October 2013, I think. And just fortuitously, Mr. Jeff Kennett, who was the chair of Beyond Blue, was invited to our Senior Medical Staff Association dinner in December. And he talked about doctors' mental health and challenged us and saying, you're the largest health service in Victoria, what are you doing about it? And so, we took up that challenge, and then over the next year, we developed this strategy after a lot of consultation, partnering with Beyond Blue, who have a lot of expertise in this area, partnering with the Victorian Doctors Health Program, partnering with Monash University, who feed us the interns. And so our strategy was launched, and we came up with the purpose. The purpose is that no Monash doctor will struggle in silence. So as we see in the, as we were talking about in the busy life of a really big, complex organization, people tend to get lost and feel isolated. They don't really know where to go to. And unfortunately, even the people who are around them don't really know what to do when, when they see someone struggling. They might, offer help or a chat, but then beyond that, what? So we set up this strategy, and, the 5 pillars of the strategy is awareness, prevention, support, partnerships, and research. So awareness is raising awareness about mental illness, and with Jeff Kennett coming to our organization and talking about it, and then the next year, we celebrate our anniversaries every year. We had David Morrison coming and speaking about bullying and harassment in the army and what we could learn from it. Last year, we had Professor Sydney Decker, who is a human factors expert and talks about the second victim, which is, when something goes wrong in healthcare, the patient is the first victim, but the health professional involved is the second victim. So we've sort of, it's just become a language at Monash Health, talking about doctors' health and well-being. And what's heartening is that when we get people for interviews, applying to us, and we ask them, why do you want to come to Monash Health? They say, oh, we've heard about this Monash Care strategy, that's why. So the word's getting around. We've received a few awards for it. In fact, in this room, we got an award last year. So that's what our strategy is about. It's still early days, but I think it's making a little bit of an impact.
Have you had inquiries from other services?
We have, there's a regular sort of inquiry. So, I do get phone calls and people do get phone calls. One of the things that I didn't talk about is, one of the things that we're doing under Monash Care is we've actually invested money in having a role called the Wellbeing Officer. And this person is a dedicated, person. She's been a medical workforce member for a long time. And she knows all the stresses and things that doctors do face. And she holds a dedicated phone. Anyone can call her, within business hours. And her phone's one of the busiest phones. She, gets called for little things like, someone not liking their roster or wanting some leave for something, to really big things about, struggling with a mental illness. So she's not a counselor. She's not. She just is there and points them to the right direction. So there's someone. We also have a peer support program. So we have about 80 of our junior doctors having received training in how to provide peer support. And so this army of doctors is spread across. These are junior doctors, the organization, and they have the skills to talk to someone who they might see struggling. So that's about Monash Care, which we're very proud of.
Can I ask, there's a question from Dr. Chris Wilson about the nuclear arms race and CV building and medical training. And I might spring this one on yourself and Bav to, do we think the balance is right? Do we think that the amount of work that people need to do to get into training programs and to succeed in those training programs is too little, too much, just right?
I was going to say, it's interesting hearing what you're telling me about Monash, because it's a top-down approach. You've actually gone out and measured metrics on your junior doctors about how they feel they belong to this system. I think a lot of places probably measure, are the discharge summaries done on time?
Well,
are
we
the
do
patients...
that too.
And I think you've actually invested in fixing that. And I think that's what we need to see more of, where the system actually cares. It's all well and good for all of us to care and push within our own peer groups and our own departments, but unless the hospital executives and there's a cultural change from the top, and it's measured, and then there's sufficient investment that directs interventions, you're not going to really see huge change. As to the question about the training requirements cause burnout, well, there was an American study done in 2004 which showed they looked at the ProQOL burnout score of interns before they started their rotations and then a year later. And there was 75% of them that were at the most extreme end of burnout during their intern year. And there is these peaks. You're coming in from an environment as a medical student where you're not expected to be responsible for things to the degree clinically, and suddenly you're in a situation where you're it and there's a dying patient on the ward that you're responsible for, and you don't feel prepared. You might be prepared clinically with a theoretical knowledge, but you don't have the life experience to deal with some of the stresses. There's a family member there crying, there's a nurse sort of shoving notes into your hand saying, look, their blood pressure is 80, you don't get prepared for that in medical school. And I think burnout needs to be addressed, and how you reduce that really comes down to preparing your juniors a lot better. When you're looking at training programs these days, it seems like the requirements to get onto a training program are just sort of growing exponentially. Like there's shifting goalposts. You might start looking at a training program you're interested in 2 years' time and decide, all right, I'm going to start ticking the boxes. I'll get a couple of papers out, I'll go to a conference and I'll do this. And a year down the track, it says, well, you also have to have done this, this, and this, and this. And you can't really plan, and that causes stress as well. And a lot of things that the junior doctors have to achieve these days costs a lot of money. There are courses that cost thousands of dollars to attend.
Tens of thousands.
Yeah. I'm used to getting a letter from the ATO saying the junior doctor category has claimed this much in self-education expenses, and you've claimed this much. And it's a huge difference. And that's because I used to be a surgical registrar. And so you had to pay a lot of money to get your mandated education. But that's a stress.
But you saw the light, and you...
Could I just say,
Yeah, absolutely.
Monash Medical School has introduced mindfulness as part of their medical training under Dr. Craig Hassard, and it's examinable, because if it's not examinable, no one will do the course. But it introduces reflective practice, and he has had some very good outcomes in terms of the impact on what young doctors and students report on the impact of that. And I think it's a very innovative and very practically oriented program.
Certainly we've identified burnout as a very big factor. And the problem with burnout is it's a multiplier factor. If you're burnt out to begin with, then those resilience factors that you have no longer function properly. It's always depressing when you take an internationally validated scale and apply it to your own population and find that you don't fit on the graph. It's always difficult. Or the first time the hospital health check was run, we realised that we had to rethink our scoring system because 7 of the 8 health districts would have failed. But that's not the case anymore. Things are changing. In terms of talking about us as a profession compared to other professions, I'd like to move to you, Mari, and I'd like to talk to you about your foundation. So you and your husband are the co-founders of the Tristan Jepson Memorial Foundation and the framework that is produced by TJMF. And it's focused on improving the psychological well-being of lawyers. And I was wondering if you could tell us a bit about the key elements of the framework and how they are relevant to medicine.
Certainly, and thank you for letting me participate today. I think we started a conversation on mental ill health in the legal profession in about 2004 after the suicide of our son, where the culture was very much, if the kitchen's too hot, you need to get out. We introduced initiated the first research, Courting the Blues, which said 1 in 3 lawyers suffer depression to the point of disability and distress. The feedback from that was lots of organisations set up employee assistance programs. Feedback, anecdotal, was it's not really making an impact on the profession. So we looked at what are some options and discovered that Canada was introducing a national standard for psychological health and safety in the workplace. And for me it was fantastic because we weren't focusing on those lawyers who are mentally ill and should leave the profession, but rather this was the whole workplace and it made an impact on everyone. A healthy workplace is good for everyone. And it addressed avoidable workplace pressures. It was very well researched. The factors are based on basic human needs: the need to belong, the need to know what our job entails, that we're valued for the job that we do, that we're recognised for that. But essentially it was a management framework for engaging staff. It is across the entire workplace that Canada has introduced this. Just don't tell the lawyers, they think it's just for them. So, but in fact, Canada has introduced it across the whole workplace, and their highest uptake is from the medical profession. And they introduced it in January 2013. And the most recent figures, I guess, is that from the Toronto East General Hospital, and it's the end of last year, that they had a 7% decrease in overall healthcare costs as a result of implementing the standard. There was a decrease in the overall days absent, an increase in staff engagement, and there was improved patient satisfaction and overall quality metrics. So it's in early stages, it is a journey, but what's critical to making a difference is management buy-in. It has to be led by management and support provided by them to implement the changes. And engaging staff means that there's a continuous feedback process so that we make it safe for people to make comments, to say what's happening without there being fear of retribution, and that their contributions are valued.
think the first hospital I worked in, I was very fortunate to work in a hospital where we had a very, very engaged executive who cared a lot about their doctors. I think first and foremost, the culture in the hospital was what they cared about more than anything else. And then the discussion, when I spoke to them and say, look, how did this become a thing? Where did this come from? Like, well, if you've got a crap culture, you have a crap hospital. And it all seems like fairly common sense. But I might just ask Anjali, in terms of what Mari's saying there about the executive taking notice and making that a priority, what is it that changed in Monash to make it a priority? What is it that made the executive change the way of thinking about it?
Well, firstly, I can't agree more with the fact that it has to come from the top. There has to be, right from the board to the executive to management commitment if anything's going to happen, in a workplace. What changed? I think it was a iterative sort of journey, but the tipping point was when the Beyond Blue survey came out, and we had been thinking about this because we've lost a couple of doctors over the last 7 years to suicide, and that emotion, especially in those departments, is still so raw. So it had been on management's mind, but then as I said, when Jeff Kennett came and spoke to us about it, it just sort of took wings and got legs, and the management committed some money to it, but more importantly committed they resolved to do something about it, and gave me sort of a free hand to go out and find what we should do, start small but then grow it slowly. So definitely board, executive, management attention is very, very, very important.
Could I just say one? Its focus is prevention, right? How do we prevent the avoidable workplace pressures that lead to the psychological harm and the factors that lead to mental ill health? And they're well documented, and they're different from a mental health program. In fact, the guidelines that we introduced have no mention of mental health whatsoever. This is good for everyone, but instead of putting the ambulance at the bottom of the cliff and saying, how do we address issues, and they've got burnout and they've got this, what are some ways that we can look at the hazards, identify them, what can we do to make it better? But it's about asking staff. And the latest research out of the UK in their mental health survey is that there is a huge disconnect between what management think and what the lived experience is. What's actually happening for me? How do I feel about the workplace, as opposed to what management say, we have this in place. And the difference is, for you, it's like reading the textbook on surgery versus being in the operating theatre actually performing it. There's a huge difference. And unless we engage staff in that at all levels, ask what the issues are for the doctors. What are the things that we could do better, as well as all other people involved in the healthcare system, and support them. And make it safe for them to talk and to say that it's not going to change.
Can I just say,
You're right. I was just really wanting to pick up on Mari's point there around avoidable harm. I think one of the things we have to accept is that we do work in quite a stressful and at times traumatic environment. And I think we can learn a lot from other professions about how we can help to protect our staff in those environments, John. So we know that we know we all are exposed to quite traumatic events, stuff that happens very quickly, stuff that has a significant impact on the people that we're kind of dealing with. Yet, what happens? We go back to work. Someone bleeds out, we do a resus, we go back to work. We deliver a baby who dies, we go back to work. There's no debriefing, there's no support for people who experience those traumatic events. And then we have this cumulative burden of caring for people over very long periods of time. Again, other professions provide a lot of mentoring, supervision, debriefing. We don't do any of that. So I think there's a lot that we actually can learn from other industries and professions, and we need to acknowledge that we do work in quite an unsafe work environment with a high risk of psychological harm. And unless we get much better at dealing with that right at the front end, and I don't think it's all about resilience training and mindfulness. I think there's actually things that have to happen in the workplace in response to some of this. Otherwise, we are going to see people continue to be harmed at work.
And I think too, if you put in that this is for everyone, not for those people who are stressed.
Yep.
It's this message of, oh yes, they think I can't cope. It's the messages you send when you don't think you're sending it, but they're far more powerful than what you actually say. So if it is, there is debriefing and you are expected to go, and that is from the leadership, the head of your teams, as much as for your junior people. This is the expectation to make us better at what we do, not because, oh, you can't cope. Then that creates a culture that things will improve. But while you make it for those who are struggling, the message is always, I can't cut it. No one will give me a job. All of those things, it feeds into it, because stigma's an experience. And when you talk about the issue, my question is always, how would you know? Unless you've experienced the stigma and it's an impact on your job, you've got no idea.
I was just going to say, it has to be a cultural change that,
Yeah.
it has to be a cultural change that occurs throughout the curriculum from medical school onwards.
Yep.
You know, you need to learn about it in medical school, but then it needs to be lived when you're actually practicing doctor. Because if you go through your formative years of medical education and don't actually experience it, that's the kind of consultant that one day you will become, and that's the kind of practitioner you'll one day become. That's a system you experienced. And you know, in Queensland, when we started a lot of our deliberations about what we were going to do, it all came from the Beyond Blue survey, after the Beyond Blue survey as well. And when our CEO Jane met with Marie and said, well, this is a great set of very commonsensical guidelines, and how do we apply this? It wasn't let's go out to all the hospitals and apply it and force them to adopt it. It's let's adopt it within our organisation first. So the AMA Queensland lives and breathes these guidelines. And once you do that, then you can go out and promote these to everyone else. And if we as an AMA are going to take this issue seriously, within our own organisation, we have to be champions. And before we can go out to the government and say we need a national set of guidelines around this in our workplace, we need to change workplace culture.
And the leaders need, even the practice leaders, the heads of surgery, the heads, you know, it's how they model this. And it's really easy to tell someone else what to do. It's really difficult to take that on board, and it becomes threatening to the way you're used to doing things. But the impact of what we say and how we say it on the people who work with us is enormous. And are people prepared to speak up in our teams? It depends on how it's led and whether they feel valued and their opinion respected within that team.
I couldn't agree more. I mean, obviously management, the executive have a huge responsibility, but I think we really need to look at leaders in the front line, you know, the unit heads, the supervisors, the people, you know, involved in training and teaching junior doctors. They need to really also step up and think about the culture of medicine, which has been there for such a long time, and how they can change it. Because I think one of the things that one of the people that junior doctors listen to most and look up to most and follow are their immediate supervisors. And so I think that level of, you have a huge responsibility, and you know, if anything is going to change, it is going to come from there.
You see it in the piles of administrative tasks that build up in the hospital wards. You know, if someone in administration says, do this, do this, do this, you can delay it forever. When you consult a new registrar, come along and say, come on, do this. It gets done.
Yeah.
You do need leadership from the top. Bav, I just want to come back to your experience in Queensland. So AMAQ has focused on helping interns to develop resilience and coping strategies with the Resilience on the Run program. And I was wondering if you could talk a bit about why you focused on interns and is the program having an impact?
Okay. Well, I guess as a bit of background, as I was saying, when we started looking at this as an issue that our organisation could provide back to our members some sort of value and try and provide some service that was missing, it really came down to, well, let's look at what's out there. So we did an environmental scan in Queensland. You know, most hospital districts have an employee assistance program. I remember calling my hospital at the time's EAP, and it was a deadline, so that was very useful. And then I called another hospital's EAP, and it took me across to a phone, like a telemarketing centre, and they said, I'll take all your details and I'll email them to a case consultant and I'll get back. And I got an email the next day, and they said, oh, what would you like to know about? And I was like, well, I'm not after anything, but I'd like to know what services you'd offer if I had some workplace stresses. And they said, well, I can give you a list of the psychologists near the hospital. I thought, that's great, but you know, this is the same EAP that, you know, services everyone in the hospital, every employee. It doesn't really take your personal circumstances or your professional category into shape. So we put together a list of things that all the hospitals were doing individually about dealing with well-being and support services, and a lot of them had very scattered approaches, some of them had nothing. And so we thought we should put something together that will help interns. And we thought about interns because we've been talking about getting this in as soon as you start practice. We'd love to start it in medical school, and I think the medical schools have a responsibility to build this into their curriculum as well. But we know that the burnout peaks in internship. That's what the international literature says. So you have to have the intervention at the start of medical school when you can put into practice some of what you're learning. So the program's centred around mindfulness training, where interns are taught to be a bit more mindful about the circumstances they practice in. There's scenario testing, there's dealing with tough scenarios. Similar to if you're in an emergency department, you have a simulation about a sick patient. We talk about the debrief, and we talk about all the other aspects of that as part of that. And there's sort of practical skills that you can take away from this. So we piloted this in 2015 at Rockhampton. And a part of the pilot, we had a control group as well up in Cairns Hospital. And we measured a whole bunch of factors, mainly because the international literature doesn't actually agree on what are the best validated tools to measure these things. So we measured K10 scores, pro-QOL, burnout, compassion fatigue, and a few other factors. And what we found was that immediately after these interns got these talks, and they actually found that it was helpful, but that helpfulness actually persisted 3 months later. And they're finding that their burnout was actually less than their non-intervened colleagues. Now, it is by no means a perfect program. The reason we set this up was because there's no other service that have offered this to junior doctors in our state, let alone nationally. There are services in various different places now that offer their own disparate programs, but there was nothing else. And we felt compelled to do something because we thought it was important. And I think as we start talking about these, more and more people have come forward with, you should do it this way and this way. I think that's all great, and I'd love to see a nationally funded program where interns have, as part of the Australian Junior Doctor curriculum, mindfulness training, and medical schools have it within their curriculum. And we wouldn't have to run interventions on 350 interns so far and try and roll it out to different hospitals. That'd be great, but at the present time, that's the only service that junior doctors get. So at the moment, we've got Princess Alexandra Hospital, Ipswich Hospital, Gold Coast Hospital, I believe Mackay Hospital's just come on board as well, and Logan Hospital, and we're trying to roll it out across the state. And the dollar quantum required to roll these sort of programs out is actually quite small. It's more the willingness of the hospitals to actually come forward and say, we value this, so come on board and deliver this program at our facility. So our experience has been mixed in Queensland. There's been some places that have been really welcoming and adopted this, and there's other places that have said, no, look, we do our own thing. What do you do? And that's a different question.
But if you can get the interns to say what would we like. So if you get constant feedback, then that's your evidence to say to your hospitals. It also means that whatever monies or you target to it, they're actually going to be more effective.
If you ask them that, they'll just say free coffee and we'll be bankrupt.
Well, I mean, after free donuts and coffee, how could we, or what do you wish we had, or put some so because it's also their buy-in. If they've got a contribution to what you put in, then suddenly this is theirs. They take ownership rather than it's imposed and put there. And anyway.
I think one thing that you point out is that you've looked at concrete examples of something that's being delivered, as opposed to the generic, here is a list of this, here is this. I think, we always talk about getting a GP and that being an important part of taking care of your own healthcare, and it absolutely is. But I would never look at a patient who's on non-invasive ventilation in my resus bay from pneumonia and say, you should have seen a GP 3 weeks ago, buddy. We could have given you some amoxicillin and knocked this on the head. And that's always disturbed me a little bit, the onus on the individual. And I might move to a question from Dr. Brian Morton on that. And Brian asks, what is the responsibility of the organisations here? What is the responsibility of the hospitals, the employers, the accrediting bodies, the medical board, APRA? A lot of the comments that have been coming up on the screen, recognising the importance of resilience and mindfulness, also say, yes, but there are significant systemic factors here. And I might also add to that, there are a few people on this panel who are also board members, and you speak risk and you understand risk. What do doctors in training, or even, but senior doctors, clinical staff associations, what language do they need to be speaking to their boards and their executives to action change? It's a long question.
Could I say that what we found with the lawyers was if you invite them to a mental health talk, no one comes, because you might catch it, or someone might see you walk in and think you have it. So through talking with different organisations, the British Bar Association have said mental health won't fly, Mari. What we say is this is an investment in your peak performance and capacity, because doctors and lawyers see themselves a bit like racehorses and elite cars, and rather than cracked urns. But the reality of peak performers and cars and racehorses is they require greater care. And unless you invest in that, sustaining your performance, given the pressures of the job you're under, are not going to be possible. Reality is mental ill health is a continuum. Things happen to all of us, life events, situations in our family as well as professional that will impact us. But if we can put in place and recognise the value of investing in this as a priority, then it is going to support us and sustain us going forward, as well as the organisational responsibility to create a healthy and safe workplace.
I agree. And John, to your point around, yes, we do have to change the system, or we do have to fix the systemic issues that create the stress and the burnout. And that's looking at rosters, the paperwork, the night, the cover hours, the supervision, and I think that definitely has to be a focus. But in changing the system, we need to involve the people who work in the system. So, someone, from top down, you really don't know what the problems there are. And so empowering people to make the change. So one of the things that we've done is that our Chief Operating Officer holds a fortnightly session with junior doctors. Anyone who can come, and it's a free session where people can just bring up things like, oh, this is what annoys me in the workplace, and then we try to fix it. And it's small things like something in a computer program that doesn't work and annoys, and so if the Chief Operating Officer just tells the IT department to fix that, it gets fixed, whereas a poor junior doctor, if they may keep putting, requests for fixing, it may take a long time. So these are really small things that we have to continue to do. There's no doubt that, the demands that the health system face versus the resources that are there, they'll always be, they're not matching. And so what can we do to, improve the way we work is something that we just have to keep looking at. And there's no end to this. It's a day-to-day job.
Can I just say, there was a large systematic review of all the suicide prevention research which came out about a year ago. And it was looking for what are the interventions that actually work. And what they concluded is that there is no single intervention on its own which is likely to have a substantial impact. And I think what we've heard today is a range of different approaches. And so I think, suicide is like any other catastrophic outcome. It's never a single factor or a single trigger that causes someone to attempt suicide. It's an interaction between a range of environmental factors like workplace stress and individual factors. So what's stressful, an environment that's stressful for one person may not be stressful for another person. So I think often we hear people saying, well, it can't just be work stress because then everybody would be attempting suicide. And I think that's looking at it a bit simplistically because it is that interaction between the individual and their work environment as well. And so there are diverse pathways to poor mental health and to a suicide attempt. And I think any intervention that gets put into place needs to recognise that there needs to be that universal approach to suicide prevention where we're catching everybody and doing some preventative work like mindfulness with interns. And in fact, there was a review recently of CBT and mindfulness programs in workplaces, and they actually found that you can increase resilience and reduce the onset of depression and anxiety through these kinds of approaches. So it's something like that, but it's also recognising that there are already people who are at risk and they need more intensive intervention. So I think something that addresses that range of risk and that continuum that we talked about before is important.
So on that, I think we're getting to the end of the session and you talk about the need for a multifaceted approach. I don't know whether he's in earshot yet, but there's a very powerful man who's probably got a blank cheque somewhere on a table in Canberra. And if in 30 seconds or less, each panel member, if you could change one thing, if there was one thing that because we have to start somewhere. We can't say it's just a multifaceted approach. If you had to change one thing, what would it be? And I'm looking at Bav, so let's start with Bav.
Oh, geez. I guess it is a multifaceted approach. You have...
I said one thing. Or a significant thing. Obviously not the thing, but a significant area of progress that we need to make in the next 12 months.
Mandatory reporting is the low-hanging fruit.
Okay. That was 5, so that was perfect. Thank you. Jeanette?
I think I'd just like to see all of us get a whole lot better and a whole lot more comfortable around treating our colleagues, providing clearer pathways to care and a very soft landing for people when they need help. When we treat doctors, we need to recognise we have patients with high levels of health literacy, fantastic understanding of the health system, but they need a safe place to be patients as well. They need their privacy assured, they need no fear of regulatory intervention, and we all need to get a whole lot better at being able to provide that for each other.
That was a very crafty way to make 5 things one thing. That was impressive. Fiona?
I was hoping I'd be off the hook because I just said that there's no single strategy, but so I suppose, I guess when I look at the flip side of burnout, it is a workplace that where people have a sense of control over their work, so a sense of efficacy, purpose and collegiality. So I think changing the culture in workplaces and that leadership, there is really clear evidence that leadership, if it drops off the perch, you start to get poorer outcomes in suicide in workplaces. So.
Kari?
Well, coming from suicide perspective, I personally think, and our colleagues recently are really interested in also what's the impact from the client's perspective, client's suicidal behaviors, how much does that actually contribute to the issue as well, but also as we are talking about here more widely with regards to the different impacts and the impact of colleagues' suicidal behaviors, I personally think that this hasn't also get enough attention. And but yeah, of course, when it comes to the medical doctor's perspective, there are several kind of more universal and activities what could have been taken.
Thanks. Murray?
I'd say cultural change through engaging your people, but to look at effectiveness of what we implement so that it's a constant feedback, it's an ongoing process of improvement. It's a journey.
Again, very hard to pick, but I think just the ability to have conversations like this at every opportunity and every level, and not just, and also focusing on the positive, all the good things that are going on there, and sharing those stories. And of course, we do have a negativity bias, so we do focus on the negative a lot. That is important. But we also have to share the positive stories about what went well, how someone supported someone really, really well, and learn from that.
Just, sorry, a brief extra question in line with those. When it comes to also suicidal, prevention of suicides, then in recent information is indicating also when it comes to the media attention that we need to share positive stories, and actually when it comes to the media, it can have quite harmful effect when it comes to suicide and suicide clusters. So that there is so-called Papageno effect recently found that if somebody comes forward and says, I went through tough times and I actually found help, this is encouraging people to seek help rather than to make the similarities that there was this young doctor and I feel so similar to that and maybe that's my way to go. So try to find positive stories. They are powerful.
But on the converse, the media is also partly to blame in hiding the issue. There was a recent high-profile case of a sports star who committed suicide, but the news article didn't mention the word suicide. At the bottom there was if you feel like you have if you're under stress or if you need help, contact this number, and that gave you the clue that he died because of suicide. There was nothing in there about him taking his own life, committing suicide, or anything to actually convey that message. So the media has to be also a bit more proactive in how they approach these and consistent.
On that, I think focusing on the positive, I might just point to the room and say thank you all for coming to this session. I think it's important that both junior and senior doctors stand up and take the lead in this space. I think, as you've heard from the panel today, that without that combined effort, we're just not going to get there and we're going to continue to face the same problems over and over again. I'd like to thank the AMA, the Federal AMA, for giving us this time and for giving the Council of Doctors in Training the support to continue to work through this issue, particularly given how close it is to us and how hard it strikes at home. I'd also like to thank the state AMA branches for supporting your doctors and the initiatives that you have in your state. It's hard to avoid the AMA and the media when you look at recent suicides or the effect around mental health and suicide in medicine. Wherever the discussion is, we're there. And without the state and the Federal AMA standing up and taking a position on this, we wouldn't see this change. Thank you to all the panel members. Thank you very much for giving up your time and for sharing your wisdom and your thoughts with us. We do have some presents off to the side that we'd like to present to you just to say thanks. So a big round of applause to the panel members for today. Thanks. I'd like to thank everybody for the questions that have been submitted. To those questions we couldn't get to, my apologies. But this is a conversation that we're going to continue to have, well, certainly for the rest of my term as CDT Chair, and I'm sure this conversation will continue for many years to come. And as Mike said yesterday, hopefully we get to a point where we're not talking about the first Indigenous otolaryngologist and things like this. I hope that we get to a national conference where we don't have to discuss this because it's no longer a problem. It's fairly optimistic and slightly naive thinking, but if we land somewhere low on that bar, I think that will do well for the profession. Thank you.
Right. Thank you, everybody. Our next address will be from the Prime Minister. The President is downstairs meeting him. So if you could just, sit quietly, a bit of mindfulness, and we'll await the Prime Minister's arrival. Ladies and gentlemen, the Prime Minister is outside the ballroom.
Delegates and guests, we are honoured this morning to have a presentation from the Prime Minister, Malcolm Turnbull. The Prime Minister can only be with us for a short time, so I'll keep this introduction brief. Malcolm Turnbull had long and successful careers in both law and business before entering politics. Many of us remember him as the leader of making the case for the Republican referendum and the 1997 Australian Constitutional Convention. He was elected as the member for Wentworth in 2004. Following a year as Parliamentary Secretary to Prime Minister John Howard, in 2007 he was appointed to Cabinet as the Minister for Environment and Water Resources. Following the 2007 election, he was appointed Shadow Treasurer and then was Leader of the Opposition from September 2008 until December 2009. He was Communications Minister from September 2013 until being elected Leader of the Liberal Party and Prime Minister in September 2015. As Prime Minister, he led the Liberal National Coalition to victory in last year's federal election. Since the election, the Prime Minister has taken a close interest in health policy and he's engaged personally with the AMA and with myself as President. I have to say that this engagement has been friendly, honest and productive. The Prime Minister truly understands the value of good health policy and is keenly aware and keenly conscious of how much the Australian people value what they regard as their very good health system. Please welcome the Prime Minister, Malcolm Turnbull.
Well, thank you very much, Michael, for that very warm welcome. Michael Gannon, President, Tony Bartoni, Vice President, Anne Trimmer, Secretary-General, AMA Federal Council, past presidents, state AMA delegates, Australian Medical Students Association, friends one and all, it's great to be with you. And to be so at a time of growing collaboration between the government and the AMA. The work you do is so important. You are the healthcare professionals to whom Australians turn in their moments of greatest need. You treat us from the time we're born and through every stage of life. You're doctors, counsellors, friends. And you always provide a reassuring, trusted voice. Meeting your Federal Council last year helped me hear firsthand from you, at the first-hand perspective of the medical profession. In President Michael Gannon, you have a leader who engages in policy discussions with government with real candour. He is a plain, blunt man and very good to know. You always know what his position is. No ambiguity, and he has a willingness to work with the government. We won't always agree, but it is very important to have an open door for discussions on health, and my government always will. Now, as Michael said, this year's budget has restored the sense of goodwill between the AMA and government because it reaffirms our commitment to health. Ensuring that the budget is on a sustainable footing enables us to maintain our world-class universal healthcare system, one that puts patients at its very heart. Healthcare is costing us much more as our population ages. And while new technologies and drugs help us live longer, better lives, it's also expensive to stay at the very forefront, at the cutting edge in every respect, putting further pressure on the health budget. And that's why it's critical we spend each dollar wisely. Now, I'm determined to ensure that we maintain our world-class health system now and in the future, and that all of our policies are fully funded. We are increasing funding every year into Medicare, the PBS, public hospitals and private health insurance. At the same time, we've delivered a fair and responsible budget that contains growth in expenditure and returns the budget to balance so that we can pay for the healthcare system Australians need. So we're making sure the money we invest in health is targeted and efficient. And we must ensure, as far as possible, that healthcare, and Medicare in particular, is quarantined from baseless, cynical political attacks. Patients must have confidence in their healthcare system. Funding for Medicare will now be guaranteed by an Act of Parliament, and the money will be there for all to see. Dedicated funding for Medicare and the Pharmaceutical Benefits Scheme will be placed in a Medicare Guarantee Fund every year, transparently, assuredly, responsibly. It's all part of my determination to give you, the professionals we rely on, the resources and the backing that you expect and deserve. Now, the Minister for Health, Greg Hunt, and I appreciated your feedback and the very collaborative approach that led up to the budget. We've listened and we've acted, lifting the freeze on MBS indexation. Our approach to lifting the freeze is responsible. It targets those services that matter to Australians the most. We've also decided not to proceed with the 2014 budget savings measures, as well as changes to bulk billing incentives for diagnostic imaging and pathology services. Our staged set of changes deliver on our commitments to guarantee Medicare and cement the critical role that primary care plays in our health system. Now, the doctors and medical professionals of Australia can expect a considered and calm approach to policy from my government. There'll be no sudden changes, no knee-jerk reactions, only clear, consistent decision-making in consultation with you that helps you deliver first-class services to Australian patients. Now, the state's hospital funding will grow by around $4.2 billion, or 22.8%, over the next 4 years. The current 3-year funding agreement is underway, and for the first time, patient quality and safety has been linked to the funding. The government also values the role private health insurance plays in our health system, and the Minister for Health is exploring sensible opportunities for reform of private health insurance to ensure its value for Australians and long-term sustainability. We're trialling significant reforms in primary care, as you know. Our healthcare homes model supports people with chronic illness and focuses on coordinated care with flexibility for the GP team to look at new ways to deliver that care. The focus is firmly on the patient, enabling them to stay as well as possible at home and out of hospital. Now, when we launched our policy, I met a patient named Michael, who sadly has now lost his fight with cancer, and I will always remember his words: "Every day I am not in hospital is a great day." This is a model that healthcare professionals have been calling for years. We've listened to your concerns and we're determined to ensure that the right system is in place that supports both practitioners and patients. Now, we will continue to prioritise mental health. This is a very, very important focus for my government. Professor Ian Hickey, from whom I have learnt a great deal on this subject, as I'm sure many of you have, speaks of the mental wealth of nations. It's a very apt phrase because it reminds us that we all have a vested interest in each other's mental health, as indeed we have a vested interest in each other's health. But mental health comes at such a great cost, not only to the person suffering, but also to their family, communities, and the healthcare system. And it has been, in large part, overlooked for a long time, for a whole range of reasons of stigma that you understand very well. Nearly half of all Australians experience a mental health issue over the course of their lives. It doesn't discriminate. I heard you had a session today on the health and well-being of your profession. That is so important. I'm a very big supporter of the Are You OK campaign. Just 3 simple words, which can mean so much to a person who needs help. There is a lot of help to be found in empathy and awareness. We're also trialling innovative ways to support people, including investing in digital trials which will put 24/7 support in the hands of those who need it, and we'll be doing more to care for the carers. We're also investing in regional suicide prevention trial sites to ensure that those who live outside of our capital cities are supported. In the work that you do, for which we thank you, there is great hope and promise which can benefit all Australians. Now, the Health Minister, Greg Hunt, and I are determined to continue our strong track record of investing in medical research and technology. While we're a world leader in health and medical research, the challenge in Australia has always been getting the research out of the laboratory and into the marketplace. The Medical Research Future Fund and the Biomedical Translation Fund will provide around $1.4 billion over the next 5 years to support our medical researchers and scientists, including through commercialisation. The first disbursements of $65.9 million from the Medical Research Future Fund were announced in the budget. They included $5 million to support the internationally recognised Advanced Health Research and Translation Centres and $10 million in grants for preventive health research. We've also put in place a biomedical translation fund of more than $500 million, $250 million of Commonwealth funding matched by private sector investors. The Biomedical Translation Fund is one of the National Innovation and Science Agenda's most important initiatives. As a key vehicle for commercialising our world-class medical research, it will provide new jobs and export opportunities, and of course, it improves the health and well-being for Australians and people all around the world. Today we make the fund a reality, and I'm pleased to announce the first investment. It has the potential to benefit the people who deserve the highest level of support, our children. We'll provide $10 million for a promising new treatment for peanut allergies in children. The research by Proto Therapeutics will help develop a new therapy to allow children with peanut allergies to incorporate peanut products as a regular part of their diet. And what a difference that would make to children everywhere. It's an example of the innovative projects the government is backing. Projects that built on the excellent medical research and technology that you and the AMA foster and encourage. And research is an issue, as you know, that governments must focus on not simply with great scientists and researchers, with medical professionals, but also with patients and their families. I've just left a meeting with Greg Hunt, who sends his apologies. I know he spoke to you eloquently yesterday, but Greg and I have just been meeting with the father of a young lady who is suffering from brain cancer and discussing his ideas and his friends' ideas about how we can do more to promote research into brain cancer and increase the survival rate of brain cancer sufferers, and particularly focus on brain cancer in children, as you know, where it is has one of the most deadly consequences and incidences. This is a leadership role in health that falls on government, that needs to bring to bear all of the elements: responsible financial stewardship, ensuring that we invest for the future into the research, ensuring that we maintain and guarantee and reassure those vital medical services that we all depend on: Medicare, the PBS, our hospital system, private health insurance. But it also needs a very, very big heart. And I know that all of you, with all of your years of academic training, all of your years of clinical experience, all of the science and the study that's dominated your lives, above all else, what drives you is love for your fellow men and women, love for your patients. You've committed yourselves to a life of service, undiluted, a commitment of compassion, and we thank you for it. Our health system is the envy of the world. Our skilled doctors, our nurses, all your allied health professionals work tirelessly to give the best possible care, and your government thanks you for that. Thank you for your dedication. Thank you for your professionalism. Thank you for your compassion. We will match you with a commitment to ensure that you have the resources at every level to continue to deliver the practical love that keeps Australians well. Thank you very much.
So, Prime Minister, on behalf of the delegates to AMA National Conference, thank you for that very warm address. We've been honoured by your presence here today and by your support for our profession and our patients. Nothing beats a face-to-face encounter between citizens, in this case your doctor citizens, and the Prime Minister, for effective communication. Regrettably for your diary, everybody's on to the effectiveness of a personal encounter, so we understand that you need to leave for your next meeting with your next group of citizens. Take with you our very best wishes and thanks. All right, that concludes this morning's session. It's lunchtime. Could you remember to sign up for the soapbox tomorrow afternoon? And we'll see you back here in an hour.